If you look on the left side of this slide here, here's these sets that are superimposed on this generalized color triangle. And this is easier to do and makes a little more sense because these disorders aren't very detailed in description. We're working on kind of a general model here. And so it makes more sense to have these as areas rather than being punctate, as in the splotches model that was triangled. What I'm now doing is then I want to make an analogy between this generalized color spindle page as represented by these overlapping sets and color terminology and map on the standard manic depressive labels, talk about how they fit into this. So if you look on the right-hand side of this slide, you can see on the far right here, there's this arousal level, and then proceeding back toward the big blue dot where it says pure color there, you see manic disorder, which has a lot of activity in it and is contrasted down in the bottom to depression, which is sort of the flip side of mania. Depression and mania are phenomenologically, in other words, they look like the flip coin of these different sides of the coin, the flip side of it. And there can be states where some manic type of symptoms as well as depression symptoms can occur at the same time if they're compatible, and that's called mixed state. But sometimes they alternate and cycle, and sometimes they'll cycle back to normal in between the manic and depressive stage, but they a lot of times just change from manic to depression and depression to mania. Once in a while they'll go back to, when they cycle, they'll go back to what's called euthymia, or they may even go to these lesser states of hypomanic or dysthymic. Dysthymia is mild depression, and hypomania, which is lesser form of mania, that can mix and cycle with dysthymia, and then of course they can all circle back to being normal at certain times. Here's these sets again with the same labels in them pretty much, but these combinations like bipolar 1, you have to have mania. Bipolar 1 has to have mania. And even if you don't have any other depression or hypomania, it's still called bipolar 1, just having mania by itself. But this usually occurs with episodes of major depression, and that's where you get the old manic depressive disorder, and that's where you get the bipolar, is basically these things alternate or cycle between mania and depression, but they can have states in between with hypomania. After you've had one episode of mania, bipolar 2 is hypomania plus major depressive episodes. This is where you have hypomania, which is mild mania, plus major depressive episodes. And sometimes the hypomania is not the big problem, and people can actually be productive and ambitious and get things done when they're hypomanic. These symptoms don't interfere with things, but the major depression becomes a big issue because this causes dysfunction and disability. Then there's bipolar 3. I don't think this is in DSM-5, the current model manual of diagnosis. But anyway, these were basically, they have hypomania or dysthymia, and these states can be precipitated or worsened by treatments of mania or depression. Then there's mixed mood disorders, where basically this is where concurrently they have manic and depressive symptoms, and they're called mixed mood disorder or unpleasant highs or dysphoric hypomania or mania. And that's this dysphoria is basically associated with usually in mania or at least in some of them they have euphoric states. But this dysphoric mania, basically mixed mood disorder. And if they cycle, they might not cycle through what's called euthymia, which is normal mood, emotional tone. So they may not cycle through normal when they're switching phases between mania and depression. So they don't always go back to being normal when they're cycling. Now, usually they do at some point, especially with treatment. And that was one of the ideas that manic depressive is different from schizophrenia, that mania and depression were episodic and would at some point usually go back to normal, where schizophrenia basically was originally thought to be a downhill course. The next bullet point down there, major depressive disorder, there's agitated depression, mixed depression, so you can have a predominantly depressive state but have some manic phenomena occurring, but it's minor in comparison to the depression. Then there's retarded depression, where people are slowed down and their thoughts, their mind, and their actions are slowed down, and so they go into a state which is statue-like and somewhat like a catatonic state, which we'll talk about later. Then there's cyclothymia, and this is a mild form where people cycle or alternate or are mixed with hypomania and dysthymia. And this is a lesser form of manic depressive syndrome, but it's more prolonged. Usually at least 2 years is the criteria. Some people think it's a personality disorder. Then hyperthymia is chronic hypomanic symptoms, again, usually 2 years running, and it's minor mania, in other words, mild manic symptoms, and usually lasts 2 years. Some people think this is a personality disorder. A new diagnosis is persistent depressive disorder, and this is new in DSM-5, which is the Diagnostic Statistical Manual of the American Psychiatric Association. And this has replaced dysthymia, which was mild depression. And it includes dysthymia, and they changed the name because dysthymia and chronic depression, chronic unipolar depression, where basically they don't have manic states, can occur at the same time. And dysthymia is usually mild depression for 2 years, but they've got this new category now. It's a persistent depressive disorder, and dysthymia is included in that. Now, in this circle here where it has pure color, and so that circle with hypomania and dysthymia in there, these disorders aren't psychotic disorders. Psychosis can be added on to manic and depressive symptoms. So there's such things as psychotic mood disorders, psychotic mania, psychotic depression, but not over here with hypomania. If you're hypomanic and psychotic, you'll automatically be diagnosed as manic, and the same thing with dysthymia. If you have psychotic symptoms, they will call you major depressive disorder. Here are some of the criteria for mania, hypomania, depression, and dysthymia, since people are going to want to know what this really is. And so this is just basically a slide showing criteria that are used to diagnose these things. Rather than having just a name for them, you can know what the criteria are. And over in the upper left-hand corner there, you can see A1, and that's a list of symptoms, and this is seen in this dig fast is a mnemonic for, you have to have 3 of these dig fast symptoms for a week or hospitalization to meet the criteria for mania. And of course, there has to be dysfunction and disability along with this. Down at the bottom there, below if you see disability and dysfunction down at the bottom, in the left lower quadrant of this, you'll see distress with dysphoric mania and mixed mood disorders. And they'll also have distress. And of course, that distress can either be you or the people that are around you, or probably both in most cases. Then up there at the top of that gray diagram there, number 2 is dig fast symptoms for 4 days. That's hypomania. You can have all the symptoms of mania, but it doesn't last for a week. Mood disorders basically signify a longer term situation than just emotion. In other words, this emotional state is going to last for a while. And they're often made the analogy of emotion is to weather as climate is to mood. And these are mood disorders. So you can have all these symptoms, the same symptoms of mania, but if it doesn't last long enough, it's considered to be hypomania. And hypomania, sometimes it's not intense or disruptive, and actually people can get a lot done and be creative and productive in those states if they're not disruptive and causing dysfunction and disability. If these guys with hypomania are hospitalized or psychotic, they're by default diagnosed as mania. Up in the upper right-hand corner, there's number 3. There's 4 symptoms of these Siggy caps for 2 weeks. This is depressive syndrome, basically, and a mood disorder has to last more than just a day or something like that. It's usually extended, and of course the time criteria for this is 2 weeks. So you got to have 4 of these symptoms for a major depressive disorder diagnosis, and no history of mania or hypomania in unipolar depression. But the same criteria, the manic depression, where you have manic depressive disorder, has the same signs as unipolar depression. And so this major depressive disorder, if you have mania with it or hypomania, then it's bipolar 1 or bipolar 2. But it's either in depression, in bipolar disorder, or unipolar disorder, the symptoms are the same. And you can read them there. This lost energy here, I got this little mnemonic that says flatten. And what that means is fatigue, leaden energy, tired, and got no energy. And this leaden is people will be so fatigued and stuff that they will report that their limbs feel like lead and they have a very hard time moving. Down the bottom left corner here, there's a 4 there, and more than 4 of these depressive symptoms for most of the day, for majority of the days, for 2 years. That's this dysthymic disorder. These lesser disorders like hypomania and dysthymia, these are basically the symptoms, and when they're tied up with time duration, then they become syndromes. But usually these lesser disorders like hyperthymia, where you have chronic mania, or chronic, this dysthymic disorder that they now call persistent depressive disorder, they are lesser intense but longer duration than these other episodic disorders of bipolar. Now these disorders, the symptom complexes that I talked about before, diagnoses are based on signs and symptoms over a time course. And so this hyperthymia is chronic hypomanic syndrome, and cyclothymia is hypomania and cycling through maybe normal euthymia down into dysthymia. So they will cycle, but they don't become manic. They don't meet the criteria for manic or depression. And that's now where dysthymia has been incorporated into this persistent depressive disorder, which can incorporate, in other words, you can go from dysthymia back and forth between depression and dysthymia. There is a unipolar depressive disorder, that's major depressive disorder, and unipolar mania. And so basically unipolar mania is still diagnosed as bipolar 1. Kreplin was the guy that came up with dementia praecox, which later named schizophrenia, and manic depressive insanity. Anyway, this unipolar depression was included in his dichotomy as manic depressive, depressive type. In contradistinction now, you got analogous unipolar mania is included in bipolar 1, even though there's no bipolarity in it. But that's, the presumption is people usually, if they have mania, they're going to have depression later on. And Kreplin included in these mood disorders are not all psychotic, so it came out to be this spectrum of disorders is what he finally came up with, and that's what's signified over in the left half of the page where there's the diagram. Before this, in DSM-5, before they came up with this persistent depressive disorder, which is dysthymic disorder plus or minus chronic major depressive disorder, they had major depressive disorder on top of dysthymic disorder, and they just called it double depression. But that double depression was not an official diagnosis in DSM-4. Okay, we're going to leave manic depressive aside for now and go through the history of schizophrenia. This is really detailed, but I think I have it written down well enough here that you can figure it out for yourself. Kreplin came up with dementia praecox, and he thought what this was. Dementia praecox is sort of like dementia, precocious dementia or premature dementia, and people would lose their intelligence and their ability to work and live, make a living and stuff. And so it's kind of a functional ending to this where you wound up demented. And anyway, he had 4 diagnoses that he threw together from other people's observations: catatonic, hebephrenic, paranoid, and simple schizophrenia. Then Eugene Breuer come along and he said these people didn't all wind up demented. There's about a third of them recovered, a third of them remain unchanged, and a third did deteriorate. And it wasn't always premature. This dementia praecox was usually people who were adolescent age onto young adults, but the spectrum is wider than that. Usually between 15 and 45 is the age range for these, and usually it doesn't occur outside that age range of 15 to 45. One of the things that Bleuler, who renamed this schizophrenia, talked about, schizophrenia means split mind, which people get confused with multiple personality. And Edwin Stransky, he was an Australian psychiatrist in 1904, used the term intrapsychic ataxia, refer to this sort of horizontal splitting of these domains. If you look down here in the middle where it says normal psych domains, this is some of the normal segments of the personality: affect, behavior, cognition, drive, effect, and so on. These usually go together, and in schizophrenia these get split apart sort of horizontally, where in contrast to multiple personality, they call it dissociative identity disorder now. Famous cases were Eve White and Eve Black, and she was sort of conscious-ridden and duty-ridden, and where Eve Black was more idish, I guess you might say, and the id is a kid, basically. And so it was cluster C-like personality disorder, and she would alternate between this cluster B-like personality disorder. So what she would show is basically dysthymia, this Maya depression, versus hypomanic states. And Eve Black was interesting. She would go out and party and leave Eve White with a hangover. And the split that you see in this dissociation is sort of a vertical split, and the personality divides. It still has some unity, and it unifies as these separate personalities. One analogy is made of schizophrenia. It's like dropping a mirror, and you have these separate segments, and dissociative disorders like dropping quicksilver or mercury, where it'll break. You take a little ball of this and drop it, it'll break into 3 or 4 balls instead of these segments. Anyway, I think this idea of intrapsychic ataxia is a good one. One example of this, and is important in diagnosis, is mood incongruous delusions and hallucinations in schizophrenia, where the emotions and the cognitions and thoughts and stuff like that don't stick together, they don't reflect each other. Psychotic manic depressive disorder, like if you're manic, you'll have delusions of grandeur and think you're powerful and think, well, you're never going to die, and if he does, he'll go to heaven and help God run things. Where in depression, their delusions will be basically that they're condemned to hell, they're going to go to hell and they're going to suffer, and everybody down there is going to torture them, and they'll have no control whatsoever. And the delusions and hallucinations of schizophrenia don't match up. And one example of this incongruity is where somebody will tell the patient that their mother or father has died, and they'll have a giggling fit over it. Kurt Schneider is a guy who worked a lot with schizophrenic syndrome, and he had these first-rank symptoms that he thought would be diagnostic of schizophrenia, but they're found in severe manic depressive disorder, and also in severe dissociative disorder like dissociative identity disorder. So they're basically signs of psychosis. And then because of trying to come to a better description of schizophrenia, they came up with this idea of positive and negative symptoms. Positive and negative symptoms are symptoms that are added on, and negative symptoms are normal behaviors that are lost. And you get these also, positive and negative symptoms, in mania and depression, but their terminology is already pretty much established. And so even though this positive and negative symptom description could be applied to mood disorder, their terminology for mood disorder is fairly well established. Anyway, Nancy Andreasen, Crow, and Little were people who worked in this area developing this concept. And so basically what it came out to be is, if you look over on the lower left-hand side corner of this slide, you'll see a triangle there with normal and a D in the middle, and then a plus and minus on top. And so what this idea is that there's positive symptoms, negative symptoms, and disorganization is actually a third dimension that's independent of positive and negative symptoms. This here is just a lot on the history and diagnosis of schizophrenia. It's too much to go over in one setting. The modern view is that you go to number 1 there in the middle of the page, you have negative symptoms. Like I said, the things that should be present that aren't. And if you look up at the top, you'll see what it is. Basically, patients have no emotional expression. They are inactive. They may even have not much speech. They may even be mute. And they don't have any motivation. And I like the word anergy. You don't have any motivational energy. Anhedonia is where you don't feel any pleasure, but people can get so they're just indifferent, don't feel pain or pleasure. Asocial, and avolition, they don't have any will to initiate or sustain things. And unhygienic, they lack self-care, inattentive. So these are these negative symptoms. They're things that should be there that aren't. So they're deficit symptoms that are subtracted from people's normal behavior repertoire and is analogous to subtractive color mixing, where you wind up down in the black area of the color triangle. And number 2 over here, positive symptoms. These are symptoms that shouldn't be there but are. They're sometimes called excess symptoms, thought to maybe be more active hyper state. They're usually delusions, hallucinations, and this disorganization, but disorganization is probably thought to be a separate dimension of its own, and then analogous to this additive color mixing. Now going to number 3, here's a mnemonic that I made up for the criteria for schizophrenia from DSM-5. They don't distinguish types of schizophrenia anymore because they're unreliable, it's said to be, and not as helpful treatment or diagnosis. But the types have more or less turned into criteria. You got delusions and hallucinations, and they're mainly auditory hallucinations. So basically, I just put the auditory hallucinations. And disorganized speech, which is actually a neat term for that, is schizophasia. And this is what people used to call word salad. And then you have disorganized behavior, which a lot of times is just called bizarre behavior, catatonia, and then negative symptoms. And of course, all the negative symptoms are listed up top. And the mnemonic for that is just daddykins. In other words, delusions, auditory hallucinations, disordered speech, disordered behavior, catatonia, and negative symptoms. So the types and categories, if you look over to the right there, you can see these out of DSM-4, there were this criteria for diagnosis. And anyway, these syndromes were taken beginning back from Kreplin, and these were the types that schizophrenia could be diagnosed into. But DSM-5 doesn't think they're as helpful as they ought to be, so they turned them into criteria, sort of, rather than type. Up here, this essence of schizotypical personality disorder, I made up this mnemonic here that fairly well summarizes it. Schizoid personality disorder is mainly these made up out of these negative symptoms here, and simple schizophrenia, which had varied status, is basically sort of a rapid onset. The schizoid personality disorder is supposed to be a long-term thing because of personality disorder. Simple schizophrenia is basically progressive negative symptoms, and this was more or less what Kreplin was talking about, the dementia praecox. This now is trying to match this set diagram of this general color page with some of the schizophrenic symptoms. I guess you'd call it schizophrenia spectrum disorders is what they tend to call them now. And so I'm matching that on this general color spindle page, and you can see I got catatonic excitement in there and catatonic stupor. They used to think this was a form of schizophrenia, and this excited states and stupor states can still exist in schizophrenia, but they also occur in other disorders. And then, of course, you can have severe disorganization, and this used to lead to basically schizophrenic type, but it's become a criteria instead of a schizophrenic type. And here's the schizotypical and schizoid personality disorders are over in this circle here, and I went through the list. There was 8 S's of schizotypical disorder, and the schizoid are mainly these negative symptoms associated here. But one thing, this circle here, these in the DSM-5 are not considered psychotic disorders, and so basically if these disorders will sometimes will vary over into these actual schizophrenic disorders where people have delusions or hallucinations, and they can sort of go back and forth in between them some, especially when people are under stress. They can show psychotic symptoms, but they generally return back to normal, so they wouldn't be considered schizophrenia. They'd be considered probably brief psychotic reaction, which is a short-term schizophrenic-like syndrome. Over in the right lower hand corner here, you got this DSM-4. They had a hierarchy of diagnostic hierarchy, and this was catatonic, dissociative, paranoid, undifferentiated, and residual. And they usually didn't diagnose as prodromal, but that prodrome, they had these symptoms like paranoid personality disorder, schizoid personality disorder, and schizotypical disorder, but they usually weren't diagnosed with the personality disorder. They just had this onset of schizophrenia that was this minor forms, and then went into the called an active form, where they had these four that are in black here, and this is catatonic. And so if these people showed predominantly catatonic features, they were diagnosed as that, even if they had some of these other symptoms. And of course, catatonia is easier to diagnose than the rest of them. So, and then the next one was disorganization. That was the D. If they didn't have catatonic symptoms, and disorganization, where basically people had disorganized speech, disorganized bizarre behavior, and usually didn't have a predominance of delusions and hallucinations. And if they didn't have the catatonia and disorganized behavior and speech, but mainly delusions and hallucinations, they were usually persecutory and grandiose and qualified for paranoid schizophrenia. And if they fit all three of those or none of them, they were considered undifferentiated. And these are the symptoms that respond, this CDPU, these are the ones that respond well to antipsychotic medications, and they would be left with then negative symptoms which didn't respond well to antipsychotics, and these would be called residual. So people would be left with these negative symptoms generally. And now there's the issue of schizoaffective disorder. The manic depressive and schizophrenia were thought to be separate disorders by Kreplin, and so he split these off into two disorders, manic depressive disorder and dementia praecox. But they overlap, as they found out, and a guy named Kassanen, like in 1930-ish, 39, decided there was a bunch of disorders in the middle that were combined, and so they overlapped in the middle of these. And of course, you don't get hypomania much with schizotypal syndrome or anything like that. It's usually these psychotic disorders, and they're mixed together. And so I made up this overlap of these two spectra to connote this. Now, well, up here at the top, there's this Yerkes-Dodson graphs put back to back, and then show you a corresponding color map here of pure hue, and then on the other end that would be a complementary color. And basically in the middle here's this gray zone where all these things mix together. I have catatonia over there in schizophrenia, but catatonia occurs in mania and or depression, and actually is about twice as frequent as in depression and mania than it is in schizophrenia. And basically you got mania and catatonic excitement up on the top, and you have depression and catatonic stupor down on the bottom. And so there is a depressive stupor that looks quite a bit like catatonic stupor. It's sometimes difficult to tell the difference between them. And over here, number 4, there is a mixed catatonia that's been observed, diagnosed, and sometimes these catatonic excitement and catatonic stupor symptoms can have a mixture of symptoms and signs also. If you look up at the top here, this graph, there's delirious mania versus catatonic excitement in red. And why I did that was basically there's a controversy. Kreplin, Carlson, and Goodwin, who are experts in bipolar disorder, think that delirious mania is the severest manic state, but Taylor and Fink, they say no, it's a form of catatonic excitement, Taylor and Fink say, and they say some of their basis for this is, in other words, if this patient comes in, they can be deliriously mania, but they consider it to be a catatonic excitement state, and they treat it with benzodiazepines, Valium-like drugs, and if that doesn't bring them out of it, they give them ECT, electroconvulsive therapy, and it works to get them out of the delirious mania state or the catatonic excitement state. These states are dangerous. People can be so hyperactive, they don't drink, don't eat, don't sleep, and they can actually wind up in heart failure. They'll just run themselves to death in exhaustion, so they got to be treated. Okay, this slide here now is down at the bottom where there's written material. You can see a big line, red line that says absent or no delusions or hallucinations, and this pertains mainly to disorganized schizophrenia, and of course DSM-5 doesn't recognize these types as useful, but I think they're still useful to talk about. And over in the right-hand lower corner, you'll see written DSM-4, and then that little p, capital C, capital D, capital P, capital U, capital R. That was the diagnostic hierarchy that went along with schizophrenia. So if you weren't catatonic and you had disorganized schizophrenia with no or absent delusions or hallucinations, then you'd be diagnosed as disorganized schizophrenia. And this took priority over paranoid schizophrenia because there's no or absent or no prominent delusions or hallucinations. And that's what the delusions and hallucinations were the ones that characterized paranoid schizophrenia. So delusions and hallucinations weren't a prominent feature of disorganized schizophrenia, and if they did occur, they weren't well organized, were fragmented and bizarre, not woven into a coherent framework like systematic delusions that occurred in schizophrenia. In paranoid schizophrenia, there are delusions of persecution and grandeur, and then reference, where people would think that incidental, coincidental things, events that occurred would refer to them. So in this one here, I just put a stripe down the overlap between the manic depressive spectrum and the schizophrenic spectrum, denoting schizoaffective disorders. And here's an alternative view of this overlap between manic depressive and schizophrenic spectrum, and this involves this Yerkes-Dodson law diagrams, and it's just an alternative way to look at it. It's not as good as I prefer the other one, but these next few slides are just going to show this, a summary of what we talked about before. So here's these sets that I drew into this back-to-back Yerkes-Dodson curves that show the same thing that came along before. And this is just a little summary of it. And of course, you got on the left is manic depressive spectrum. On the right is schizophrenic spectrum. And then down the middle is schizomanic depression up at the top intersection. Schizoaffective disorder mixed. And then schizodepressive disorder at the bottom of the arousal. Some people don't like the terminology schizomania or schizodepressive, but it's in the literature and is quite descriptive. So this is the color spindle from Munsell's system, and the advantage of this is his system has a tilt in the diagram the horizontal aspect of this diagram, but what this shows you is that they all run into this gray area. And so like the yellow would be manic depressive disorder, and the blue down at the bottom would be schizophrenic disorders. And you see, they all run into this common area, this gray zone. And just like where you're having delirious mania and excited catatonia, likewise down at the bottom you have depressive stupor or depressive catatonic stupor. They all tend to run together, these symptoms do, and seem to be mixed together, which makes you wonder about dividing these things up. There was a concept of unitary psychosis, and Kreplin came along and had a dichotomy, but they all run together, so it makes you wonder about this unitary versus dichotomy. Kreplinian dichotomy, it's called. Here's putting this into this spindle more. In the middle, you can see where basically there's kind of a core of syndromes or signs and symptoms, and over on the right, it shows it more at the peak of the spindle, and down at the bottom in the middle, there's a restriction in the range of symptoms and signs, positive symptoms and signs, or a mixture of these into this common core that aggregate around this vertical arousal axle. For instance, positive symptoms are seen, of course, in delirious mania overlapping catatonic schizophrenic positive symptoms. Of course, there's an arrow going up at the top up there. Then in the bottom, there's negative symptoms of retarded depression versus similar negative symptoms of schizophrenia and or catatonic stupor. Now there's a black arrow pointing down to that. Then as you go up through that middle, there's kind of a core of symptoms there that if you approach the middle, you get talking about the idea of schizoaffective disorder, and then you see schizomania, where the orange arrow is pointing up to the same basic circle that there is for positive symptoms, and schizoaffective disorder is in the middle, schizoaffective mixed, and then schizodepression down on the bottom. So there seems to be overlap in these symptoms of these syndromes. So anyway, is this model any good? Does it help you at all? Well, if you take, over on the left, there's the spindle, and if you take the color wheel, in other words, the waist of that spindle, and, well, I made 4 Venn diagrams out of it. Basically, you're talking about these axes, then they're labeled mood disorder, anxious disorder, schizophrenia, and delusional disorder. What is schizoaffective disorder? Well, one of the criteria for schizoaffective disorders, you have to have schizophrenic symptoms only for 2 weeks. And that's to make sure that the psychotic symptoms aren't a manifestation of psychotic mood disorder. And so this disorder seems to, talking about alternating and cycling, that basically mood symptoms and the schizophrenic type symptoms all can alternate or move back and forth across to schizophrenia, manic type or mood type disorder and predominance. And so it seems like it can cycle and alternate back and forth between schizophrenic-like disorder and mood-like disorder, or it could seem like it could go up and down the arousal axis because you have schizomania and schizodepressive disorder. So to that extent, maybe this model helps a person understand the concept. This here slide is a mess. So if you look over on the left, there's a triangle up at the top right left-hand corner, and negative symptoms seem to overlap with depressive symptoms, and they do. And they may be caused by something different, but if you're going to sit around being active, that's not going to give you much to go on, and it's going to look pretty much just like the same inactivity from depression or negative. But what's interesting is if you take the opposite of these symptoms, basically the opposite of these negative symptoms of schizophrenia, which look so much like the symptoms of depression, they actually look more like mania. And so there seems to be a common final pathway for these and symptoms. Actually, it's been postulated that the manic symptoms and the positive symptoms in these disorders probably have to do with cortical limbic pathways. So the thing that's interesting is antipsychotics that are used to treat positive symptoms of schizophrenia are also used as manic medications, and they'll be used as an antipsychotic in psychotic mania, but they're also used just as mood stabilizers. So these have probably some common neurological brain pathways. Anyway, going down here where there's a pentagon and number 3, positive symptoms are not the opposite of negative symptoms. They don't cancel each other and can be superimposed. They're not negative or positive in the sense of bad or good. It's basically whether they're present or not. Down in number 4, there's a hexagon. It says the absence of negative schizophrenic symptoms should raise the possibility of manic illness. Is suggested here that they're the opposite of these negative symptoms. So if you treat depression, you should get rid of your depressive symptoms, and if you overshoot, they'll have manic symptoms. If you treat the negative symptoms, you can get positive symptoms also in schizophrenia. So it's kind of a mishmash.